So, good morning, everyone. I'm very pleased to welcome you all to the main stage panel discussion. We're going to shine a light on health inequalities during the COVID-19 pandemic. We'll focus on current learning, what changes need to be made, and the Healthwatch network's role in tackling these issues. I'm delighted to be joined by such an august panel. I've never been in the company of so many OBEs. I think the collective noun is an eminence. Joking aside, it's fitting that we've been able to bring together some of the most committed and serious and knowledgeable thinkers and doers to focus on this really important issue. So in this panel discussion, you will hear from Joan Sadler, who is the Director of Partnerships and People.
Quality.
Yeah. Dr. Jenny Harries, who may be running a little bit late, but hoping to join us, Deputy Chief Medical Officer for England. Jagtar Singh, Chair of Coventry and Warwickshire Partnership NHS Trust. Caroline Waters, Interim Chair, Equalities and Human Rights Commission. And Anna Severwright from the Coalition for Collaborative Care. So, just to remind you that due to the size of the session, the participants will be on mute, but there is an opportunity to ask questions all throughout through the Q&A box in the middle of your screen. So before we hear from the panel, I'd just like to say a few words. Health inequalities are a long-standing and a mainstream NHS business. So the founding principles of the NHS include universality and equity. The 2012 Act gave NHS England a legal duty to reduce inequalities, access and outcomes. And the Equality Act in 2010 established the public sector duty to address equality. So this is nothing new. Yesterday, we at this conference heard from Sir Michael Marmot that 10 years on after his original report on health inequalities, improvements to life expectancy have stalled and declined for the poorest of 10% of women, and that the health gap has grown between wealthy and deprived areas. So in the cruelest way possible, COVID-19 has shone a spotlight on the link between inequity in health and socioeconomic inequity. Age, ethnicity, postcode, these variables are linked to stark disparities in rates of hospitalisation, ventilation, and death. So for the Black, Asian and minority ethnic population, the disproportionate impact of COVID-19 has been horrifically visible, a real illustration of health inequity. And for weeks, we looked at newspaper pictures of predominantly Black, Asian workers who had died of COVID. It soon became clear that these high rates of infection and acuity and death were being mirrored in the wider community. The recent review led by Doreen Lawrence concluded that structural racism led to a disproportionate impact of the coronavirus pandemic on Black, Asian and minority ethnic communities. Inequality costs lives. Professor Kevin's report for Public Health England made 7 recommendations, ranging from gathering the data to engaging with communities. All of the recommendations are deliverable and impactful. So for me, the challenges that I would put forward as my priorities, the first one has to be applying the lessons learned from the first wave of COVID-19 in order to avoid a repeat of the tragic exacerbation of health inequalities in wave 2 and any subsequent waves. And the second challenge must be to dismantle structural racism and inequity that is blighting lives, squandering human potential, and costing NHS resource. I will now invite each panelist to give no more than 2 minutes on their view of the biggest challenge related to COVID-19 and health inequalities. Now that is a challenge in itself, keeping it to 2 minutes. And if possible, could you include in that your view about the role of Healthwatch within this? So turning to Caroline first.
Thank you. Good morning, everybody. I mean, I think my key challenge to you is all about inclusion and those structural inequalities. So any body that delivers public functions should be using the legal and analytical framework provided by the Equality and Human Rights legislation to tackle those health inequalities. This means being able to demonstrate that decisions are based on good evidence collection, sound analysis, and clear action to target those inequalities. It's not enough to know they exist, we have to tackle them. There's no doubt whatsoever that the COVID crisis has shone that very light that Danielle just talked about right on pre-existing inequalities. But can you be sure that your health and social care services really consider the needs of all the people you serve? Are all the members of the community able and willing to access existing services? What about those with protected characteristics? Is it going to be worse post-COVID? Healthwatch teams are critical in ensuring patient voice is heard, developing service user perspectives and the data that underpins it. We need to understand the picture locally and nationally, and where it highlights issues, we need clear action plans to correct them. The time for standing by is gone. Using good quality data is essential. If the local joint strategic needs assessment isn't up to date, if it's not reflective of local communities, how likely are they to be understood, let alone tackled? So integration remains challenging for health and social care services. However, it's essential that equality considerations remain at the heart of service planning and prioritisation. We all believe it's vital to improve population health by tackling the causes of illness and the wider determinants of health by region and by area. Now, that gives us two strategic points of information, but in my book, you always need three to understand where you really are. It's about triangulation. So we must also consider the experience of people with different protected characteristics, or the danger is that we'll leave them even further behind than they already are. So the more we disaggregate the data and hear every voice, the more likely we are to understand what is happening and to take effective action to ensure that everyone gets the services they need. Organisations who are diverse at every level are more likely to understand the needs of those different communities. That's why it's a critical principle of the NHS workforce race equality standard. A key question for Healthwatch is, how diverse are you? What about your volunteer workforce? I understand it's about 4,000 people. That's a lot of opportunities to create a rich and representative voice and to demonstrably understand and tackle health inequality across this land. And that's our opportunity. Thank you.
Thank you. Thank you so much, Caroline. I'm going to now go to Joan. Obviously, you've got a viewpoint looking across the whole of the sector. And again, it'd be really good to hear from you about the challenges.
Okay. So I'm just going to talk very quickly about the biggest challenge I see. And the biggest challenge is that for at least over 20 years since I got involved in a board capacity, a board level role with the NHS, we've been talking about health inequalities as important, and actually what the COVID-19 opportunity, let me put it that way, told us was that health inequalities are still seen as expendable. They're non-mandatory priority, and where the crisis predominates, then the system goes into a command and control way of operating that says, let's just treat what's in front of us. Yes, we do have to, sorry, I don't know if anybody else can hear that noise, but if you can just mute, thank you. Yeah, we do have to make sure that we've got more beds, absolutely crucial that we deliver the capacity we needed. But we also need to, just as importantly, look at prevention and to make sure that people, real people using services, are engaged in delivering those messages. And as you saw with the Kevin Fenton work, which has been mentioned already, the Public Health England engagement report, which almost didn't get published, that says something. You know, engagement and community activism is really going to be important if we're going to move the the health inequalities dial and reduce health inequalities. So I think then, in short, it's unhelpful to say we're going to prioritize health inequalities without understanding that you need an army of community-minded, community-seeking people who understand the discipline it takes to convert information into intelligence. You need that army working with you, and that's real system working. I think Healthwatch is one of those entities that can be a critical part, a concerted voice that speaks through people using services and on behalf of all people, so that we don't have this pitting of equalities areas against each other, but we're speaking about everybody and the importance of inequality for all. As we see, there was a disproportionate impact on BME communities. There was also a disproportionate impact on people with mental health difficulties, learning difficulties, people with domestic violence concerns, people who were homeless, and many of those were actually acted upon. But was it enough? And if we look at the care homes travesty, I see someone's already put a question in the box, you know, that's a case in point. Where can Healthwatch really bring a voice and bring a campaigning voice? It's to learn those lessons, particularly around the care homes travesty and the ongoing disproportionate impact of people who are dying from COVID-19. So over to you. I know Healthwatch activists, I'm going to call you, they're usually up for a challenge. And I think we need to do that together as a system.
Thank you very much, Joan. And we're going to hear next from Anna. Anna, if you could give us your view on the challenges and the opportunities for Healthwatch to be involved.
Good morning, and thank you for having me. I feel very amongst some very impressive speakers, so thanks for having me. And actually, I've left the Coalition for Collaborative Care. I'm now one of the conveners for Social Care Futures. But both of those organisations were really based around hearing from people with lived experience and co-production, and having people who use both health and social care services at the heart of the organisation, and not just having people as an outside voice. And I think that's where Healthwatch is really powerful, that you are hearing from people that actually use services. And I think within COVID, what it's shown us is that when the health and social care system are under threat, and don't get me wrong, this has been a mighty challenge, and I know the word unprecedented has been bandied around an awful lot in recent months, and I'm not in any way diminishing the size of the challenge, but actually often organisations start to cling back even more to power and to say, actually, we need to just do what we need to do and survive. And listening to that patient voice and that community voice often is the first thing that goes. And I feel, therefore, for things like health inequalities, you cannot start to reduce health inequalities without involving people from really diverse backgrounds and having those conversations with the community. So that would be my first really big challenge, I think, of COVID. I think we need to look at how we can bring back in the patient voice in a much stronger way, and not just in kind of a tick box exercise, but actually involving people that use the services in the design of services. And I often hear things that I think subtly blame people who might be labelled as having a health inequality or being from a protected background. So we talk about the hard to reach, or the digitally excluded, or the difficult to engage. And actually, I don't think anyone's difficult to engage or hard to reach. It's just that we're not doing it in the right way, and we're not even trying to get out there, and we're not speaking to the right people, and we're not actually doing it in ways that people understand or want to speak to us. We're expecting them to fit into the NHS box and come to a meeting at a time that's completely inappropriate and they can't understand. And I feel like with COVID, communication's been a real issue. I haven't seen any of the government guidance, for example, in Easy Read or with sign language interpretations or in different languages. And I think this is kind of basic stuff. And at the beginning, everything had to be done quickly, but we're months in now. And I think we need to be calling for real inclusive communication that actually does speak to much wider diverse audiences than what we have had so far. I think, as people have already said, it's just exposed the inequalities that were already there. We've seen how over the last 10 years and before, you know, the gaps have widened, and I think Healthwatch has got a really powerful opportunity to make sure that you're gathering experiences and voices from a really wide range of people over the next few months as COVID continues, and making sure that those voices are getting heard at every level. So I'll stop there. Thank you.
Thank you very much, Anna. That really does resonate, I must say. I'm going to move now to Jagtar for your views.
So I couldn't agree more with my previous speakers. Danielle, you set the scene really well with the issues that we've got to face. And Joan and Joan, Caroline and Anna have just highlighted those issues. But I'm going to just take us back to Black Lives Matter and COVID. These two issues this year have exposed the inequalities in this country, and particularly for BAME. The issues for Black communities in this country have been that they have lost hope. They've lost hope that in 1993, when Stephen Lawrence's murder occurred, we thought that was a point in time in which things would change. And as Caroline has highlighted, the thing that changed was the law changed. We also had equality impact assessments introduced. These were going to get rid of institutional discrimination. They have failed to do that because the legislation is weak and it's not enforced. Therefore, what can we now do then? We can't rely on the legislation, that's for sure. Therefore, we've got to focus on reducing the gaps. As we've already highlighted, the gaps tell us where the data says that certain communities, such as BAME communities, are most at risk. People in certain postcode areas are most at risk. We must focus on the most deprived communities and stop this general whitewashing the whole country, say everybody's at risk. If we work with the most at risk communities, we'll also affect others in surrounding areas. We must understand our data better. We must use the past research and its recommendations wisely because it's already there. There is nothing new that we need to do that hasn't been researched. Marmot highlighted it 20 odd years ago. So if we're going to do new research, let's focus the new research on going beyond the past research and not merely repeating it. We must use our limited resources to maximum benefit. Leadership and accountability come out time and time again when you talk about equality. For me, this is about personal leadership and personal accountability. If we all took personal leadership and accountability, we could achieve a lot more. We must learn from the past case studies. And I'm just going to post here 4 case studies that I'm happy to share. I'm happy to share inequalities that I personally have led on in the fire service, in the ambulance sector when I was a NED, in the acute, and in my mental health and community trust. But in 2 minutes, it's hard to say, here's a case study. Partnership, working and collaboration are the key. And that brings me to that role of Healthwatch. At Coventry Warwick Partnership Trust, we have regular meetings with our Healthwatch. They provide us with advice, they provide us with support, they bring us data and research. We also help them to identify areas we want to look at more deeply. It's a proper partnership and proper collaboration that helps to drive our performance and our focus on the areas where we need more co-production. I'll end on that.
Thank you very much for that, Jag, and there's plenty for us to unpack there. I'm going to just ask a couple of questions each and then open it up to the wider group. So, Caroline, we've seen the data on the disproportionate impacts of the virus on particular groups. We've got the narrative from people in those groups, in the Black and Asian minority ethnic groups, from Professor Kevin Fenton's report. And we've now got the Doreen Lawrence report concluding that structural racism overexposed, underprotected, stigmatized and overlooked Black, Asian and minority ethnic groups. Now, there's still debate about the use of the phrase structural racism. And what I wanted to hear from you is, in your view, how useful are the concepts of structural racism and broader systemic inequity in helping us to understand and organise how we plan to address the health challenges that we face in this pandemic and beyond?
So the concept is helpful because what it tells us is that this is complex, that we, and that everything actually is integrated, and that if we're going to resolve this, we have to look broadly. So we know that there were lots of different contributing factors. So we know there were issues about housing. We know there were issues about whether you were more likely as a Black or Asian minority ethnic individual to be on the front line. And we know that relates to inequalities in access to work, because we know we find more people from those communities in lower paid, frontline, often unpredictable work. And therefore, those groups will then face a perfect storm. They're more likely to die from contact with COVID, and they're more likely to experience financial hardship. So that sense of there is not one solution. We won't fix this just in health. We won't fix this just in employment. We have to look at housing, transport, education, all of those things. So in that sense, I think it is helpful. Just coming back to the law, we actually have really strong legislation. We're envied around the world. The problem is we have to have the appetite to enforce it, and we need the peer pressure. We need people to want up and say, no, I have rights, I have protections, and I am going to require those to be enforced. And I think that's a fabulous opportunity for organisations like Healthwatch, who are out there in those communities, to say, okay, we've asked nicely, we've raised our voice, now it's time to demand. And the law is a legitimate and powerful tool to enable that.
Thank you, Caroline. And Joan, just picking up on Caroline's points about accepting that structural inequality, structural racism, those terms are useful in helping us understand the wider determinants and how it isn't by simply just focusing on health that we will tackle these issues. So drawing upon your track record in this area and the fact that you can look across the whole of the NHS and see what's going on as much as anybody else can at a national level. What are you seeing that's actually working, and what should we be doing more of, and what do you think it's time to stop doing? Oh, you're still on mute.
I'm just, yeah. So what's working, and it actually almost gets in the way, because what's working is that those organizations that understand the necessity and power of working across a system are cracking the health inequalities piece. And by that, I don't mean, so we all know that there is a long-term journey to crack health inequalities. It doesn't fit the political timeline, and it certainly doesn't fit organizational timelines, who's in charge, who gets to be on a board for 5 or 6 or 8 years if you're, lucky. There is something about making sure that those 20 or 30, and I will say acute trusts, out of quite a number of trusts across the country who have been doing this for years, have been doing this with their community partners, with stakeholders, with not seeing themselves as a hospital or even a CCG or even an integrated care system, ICS. They haven't seen themselves sometimes as a lead, they've seen themselves as part of a problem and a solution. So we know that what's working is those people who have a forensic eye on the data, on the leadership for these issues, and understanding the issue, not just as, oh, we've got health inequalities over here and workforce over there. It's the most dangerous thinking at the moment, I think, to start separating inequality and health inequality. It almost feeds into a racist agenda, if we really want to put it that way. Inequality is inequality. And I love the first speaker, sorry, I've forgotten your name, when you talked about the equality and human rights framework is an absolute tool for us to deal with inequality, whether it's health, whether it's accessing services, we must use it more. And that's where I think the cross governmental nature of our way of dealing with health inequalities will be powerful. If other stakeholders aren't leading, we as health can lead, because when I last looked, we provide jobs quite a bit. We are anchor institutions within our places geographically. We do provide or are able to provide land for housing, and we're also able to provide green space. We need to be thinking outside in those transformational terms, rather than traditionally doing what we've always done.
Thank you, Joan. And Anna, Jagtar talked about the importance of not going and doing more research into areas that have been researched already, but making sure that anything that we do research is adding to the knowledge and really taking the agenda forward. Professor Fenton talked about doing community participatory research, where people are working together, academics and people in the community, as equals. So this seems to play to the sort of arena that you're involved in. I wondered, Anna, whether you've got any examples where you've seen this type of work actually being effective in practice, and any tips or suggestions that you have for Healthwatch in terms of taking on that approach.
Around research specifically. So I think for me, it's about who's identifying what needs to be researched. So often I think it's done in kind of, it's the way it's always been done before. And we've seen, I think, people have talked about the institutional racism and things, and actually in academia, I think that's probably also a real problem. So actually, how do you get the people that are affected by the health inequalities to be driving the agenda for the research that needs to happen, and actually also being a part of that, being the researchers and being involved. Now, that's not a quick fix that's going to happen during COVID. That's a really long process, and I'm afraid I don't have any really quick answers for that. I've been involved as a disabled person in social care, in meetings where we try and give our opinions on what we think needs to be researched in social care, for example. And now we're actually running an inquiry that's led by people with lived experience, 12 of us, into what we think the next steps of social care are. That's obviously not really for this discussion, but it's just an example of where actually we've said, right, enough is enough. We're going to actually sort of do the leading now and try and change shift the power the other way around. That's probably not really answering your question, but I just think it's about who sets those agendas and how we hear from. And one of the worries about COVID is it's great, but that we can now zoom in. But actually, is that the right way to be hearing from everyone? And are there times where we might actually need to go out and have conversations in different ways, in different formats, with different people, to hear what they think needs to change, not just what the usual people who are happy to use Zoom would think need to change.
No, thank you, Anna. I think that absolutely does answer the question, and I'm sure that we're going to just open up to the group in a minute, that there'll be questions along those lines. I'm just going to, I think we might have lost Jagtar actually. Oh, you're there, Jagtar. Now I'm going to ask you a question. If you could stand in for Jenny, because we've lost Jenny Harries, Deputy Chief Medical Officer. And so this is the question that I would have liked to have asked her, but I know that you're on the calls, and I'm on the calls as well with all the other chairs. So we do get a sense of what's going on more broadly. So, we're in the eye of the storm. We're heading into lockdown again. Communities and health workers are exhausted and traumatized, but we're all still committed to working through tackling this pandemic. To what extent has the recovery of services from the first wave that we've begun on, has it started to address health inequalities, or are we simply going into wave 2 with the risk of further exacerbating health inequalities? In your view, Jag, what have you seen that makes you feel about what shape we're in going into wave 2? And
So,
also, again, the role of Healthwatch within that.
so first of all, I would say to members of Healthwatch, don't fall into the lazy assumption of restoration and recovery as highlighted by NHS England. There are a number of provider trusts that provide different services. Many carried on business as usual. So my trust, Mental Health and Community Trust, probably maintained 95% of its services. The 5% we moved to support acute trust to get the early discharge. Then you've got GP surgeries who have also been phenomenal in the way they've dealt with wave 1 and wave 2 and the more agile working they've done. However, the acutes have found this really challenging. One, they've had to create spare beds, close wards, and therefore some of the services that are provided have had to be closed in preparation for the COVID surge. So there are different provider trusts in the NHS have got different challenges. And the way the media painted is as if everything stopped just to treat people from COVID. Acutes carried on doing its treatment for cancer and others. Now, my concerns here are, in partnership with Healthwatch, we need to A, get that message out, and B, get people who need the services to access the services. If you're due a cancer, breast cancer screening, go and get it. If you're due a second operation for heart condition, whatever, go and get it. If you are an acute end of diabetes, carry on getting your diabetes, because otherwise we are going to end up with worse deaths caused by non-COVID matters than by COVID itself. So I think we should be working greater in partnership with Healthwatch. We should be talking to our communities in a much, much clearer way. I think the government have failed us in the way it's communicated its messages. It's as if there's only one message, and that one message needed to be nuanced for particular groups. It needed to be culturally competent for certain cultural groups. And that would be my greatest criticism. Also, it needed to be targeted where the greatest risk was, and that didn't happen at all either. So I think I could go on this point, but I think I'll leave it at those few key points that you just asked me about.
No, that's absolutely brilliant. Thank you, all of you. So stand by now. We're going to have some questions from local Healthwatch participants. So I'm going to hand over to Brian and Ben, I think it is, who are going to be reading out some of those questions for us.
Hello, and Bren here. The first question we have was actually for Dr. Harries, but I think other members of the panel may have a view on this. So we will follow up later, but if anybody has a view on this, we would be interested. And this is from John Beale at Healthwatch Leeds, where they've done a lot of work with care homes. In the light of the open letter yesterday from the National Care Forum, signed by over 60 organisations calling for relatives to continue to be enabled to visit during the imminent lockdown, what are your plans to do this, given that a blanket ban on visiting denies some of our most vulnerable citizens their basic human rights? So any thoughts about the implications for that from the panel?
Very tricky. Jag, you've volunteered to join the fray. I'm
just going to do a very simple answer. Blanket bans of anything are inappropriate. We should be doing a risk-assessed approach against the benefits of the visit. So, for example, in mental health, the benefits of a visit from a parent carer outweighs the risk. And if you do it in a manner in which you protect both the individual, the staff, and the visitor, it can be done. I'm not saying that we should be a free-for-all with everybody visiting, but it should be risk assessed. looking at the benefits of the clinical benefits for the patient.
Can I just add? Sorry, it's Joan.
Caroline and then Joan, sorry.
Yeah, thank you.
Yeah, I mean, I would like to bring those two things together, because I totally agree with Jag around, you know, blanket statements and the responsibility of government around what they communicate. So, you know, arguably somebody saying that everybody over 75 was vulnerable led to a direct impact on their ability to exercise their human rights. And we saw that in the denial of service, GPs refusing to go into care homes. We saw it in the mass application of do not resuscitate orders without any communication with families, and that affected older people, people who have disabilities, people from all sorts of different vulnerable groups. So there is something incredibly important as we go forward, that those who are in charge have to be very careful about what they say and understand the implications. And that's where the tools, things like the public sector equality duty, gives us an opportunity to test those kind of statements at the concept stage directly with the communities who will be impacted by them. And you could argue that had we had age agnostic treatment, then we wouldn't have seen over 40% of all deaths in care homes.
Thank you. Joan and then Anna.
Yes, quick one from me. I think this was aimed, I think, at the medical director, Jenny Harries, who couldn't attend today. I think we take it up. There is something about saying what is just an untenable situation, and we have to deal with it as a system, actually, and it's within the gift of all of us to follow that up with you as Healthwatch quite closely, that there is a change. Can I say the evidence tells us when people are in high-risk groups, they just are. But then how we deal with it has to be in conjunction with communities, as just been said. So I think we need to take it up with the director.
Thanks, Joan. And Anna?
Yeah, we were one of the organisations that signed that yesterday, and I think that letter, and for me, it's about how we prioritised during this pandemic. Like, I think it was a knee-jerk reaction. Care homes sort of got a bit forgotten. Social care felt quite forgotten at the beginning, and then suddenly we realised what was happening, and we shut them down to protect people. And perhaps that was right at the time, but actually now we've got to remember that people living in care homes, most of whom are older, but not all are older, they've got rights as well, and their mental health matters, and it's their home. And I think we now need to be looking at individuals. It's about seeing, I think the system is very good at labelling people, so people get labelled as vulnerable or at risk. But actually, how do we see each person and have a conversation with each person about what risk they are actually at and what risks they wish to take? And each individual will make a different decision on that. And how can we then, as a system, facilitate safer visiting? There are ways, you know, as I say, not free for all, like Jagtar said, but how can we look at moving forwards in a way so that people's rights are also protected? But it's about seeing people as individuals and having those conversations with each person, because each person's situation will be different.
Thank you, Anna. So a tailored approach. Bryn, have we got any more questions? Brian.
Yeah, sorry, Daniel. I'll just read one from. Sorry, I just lost it. From Lee Adams, and he asked that, given that we've had inequalities for 100 years or more, and in modern times, all services have been made aware of the different types of inequality, and given that much must be done by central government to tackle this, what makes the panel think that government might act now when they have not done so for many years?
Right, very challenging message. I will ask Caroline if you would like to go first.
Yeah, I mean, you know, you would think that during this particular period where we have had mass production of data, lots of reports, that there is no escaping the fact that we have inequalities. That has to mean that government moves to action. And that action, I think they have to understand, has to be informed by the lived experience of the people that are the subject of it. So, you know, we should have got to a point where there is no way that government cannot see its responsibility, that we have a mechanism for holding to account. I think Healthwatch locally can help gather that data, help in that holding to account. And then we have to be absolutely clear that we will not accept another report, that what we want is action, and that that action has to be systemic, and it has to be one of the most difficult things for government is to be joined up. But the only way we're ever going to solve this is to have that joined up strategy. At the Equalities and Human Rights Commission, we've been asking for years now for a strategic roadmap around race equality. That's what we need now. And also, I would say, we need to learning, because, you know, the life expectancy, the life conditions, the life choices for a Black person who is 20 is very different from one that's 40 or one that's 60, or, you know, where you are on the socioeconomic scale. So we have to be able to have this ability to build things that are more and more tailored in terms of the pathways, a bit like the work we've seen around the treatment of women with breast cancer. We need to be able to have this collective vision, but individual experience.
Thank you. And Jagtar.
So I absolutely agree. There are three points on this. One is my earlier point that it's an individual personal responsibility of all leaders. If we keep pointing to the government, we'll continually fail. So that's the first point. The second point I'd like to make is, yes, I agree with Caroline. Absolutely, the government have failed to bring a coalition of government departments together to say health inequalities, a minister for health inequalities that works across education, housing, health would absolutely support this if they got it. The other point I'd like to make is a much more positive point. If we look at the first Marmot report, the second Marmot report actually said we've made some improvements. The last one says we haven't made the significant improvements we should. Health inequalities is not a destination. We're never going to get to absolute parity. It's a journey. If we continue to manage our thought processes improvements, we are improving all the time. There are incremental changes. But what we're asking for now under COVID and under Black Lives Matter is we want some transformational change. We're not expecting the gaps to be absolutely parity. We're expecting improvement. And I think one of the areas we just veer off health inequalities to workforce inequalities. If we look at workforce race equality standard, there are many organizations, as Joan said earlier, that have actually narrowed the gap on discipline rates for Black staff in board disparities. But those that don't care, I was going to use a rude word there, those that don't care have made no change and no difference. So the Commission for Equality and Human Rights, whose role and job it is to enforce the law, need to focus on those that are not making any change, that are showing no commitment and not applying the tools such as the equality impact assessments or the duty of due regard. And that would be my sort of balanced view, rather than saying it's either or. We made no changes in 100 years. We made significant changes, and the health of our communities is improving. And a final little case study, Jack Singh, at 54, went to the doctors, and there was a poster on the wall saying, are you over 50? Yes. Is your waist more than 38? Yes. Are you Asian? Yes. You may have diabetes. How do they know that? Because people gave their data about their ethnicity, which highlighted that Asian individuals could be more liable to diabetes. So we are using data when it suits us.
Thank you. Thank you very much for that, Jagtar. So we've heard some really important messages there. Anna?
I just want to come in really quickly. You know, I've spent, I suppose I've been more in the past involved in like disability rights and fighting for those, but actually certainly since Black Lives Matter things have happened, I've realised that it's not, for me, it's not just enough to be like not racist. You know, actually we need to all be allies on this and to be speaking up when we see these sort of institutional racisms, or when people tell us, you know, our friends and colleagues tell us that what something that's happened for them. And actually, I suppose I want all health watchers and all people out there to, I'm trying to learn, I'm trying to educate myself now more into these other issues that I was a bit naive about, if I'm honest. And I think it's for everyone to kind of try and educate themselves and to then become actual allies, and so that the government have to do something on this. We're all asking for the same thing, we're all championing this and all saying this has got to, we've got to take action now. They can't just sit back and, you know, do a few things and then sort of park it again. I think we've all got to.
Thank you. So there's a really strong emerging thing about personal responsibility and about working across agencies and organisations. Joan?
Yeah, just a quick point for Healthwatch. Now, obviously, there is a NHS priority with money behind it for the first time in ages on health inequalities and reducing health inequalities. Simon Stevens taking the lead on that personally. There are 44 ICS integrated care ICO integrated care organisation plans around health inequalities and what people are going to do about it. You know, Healthwatch, as I understand, with 4,000 of you and the political power that you will have to get into those plans to say, and what's happening here in terms of care homes might be just something you think about, because that's happening now. That is within our gift.
That's such an important point. The time for influencing is right now. Bren, could we have another question, please?
We can indeed, and this one's from Milton Keynes. They've been looking at right to access primary care over a 2-year period and are still finding accessing services discourages some vulnerable people, including homeless, migrant workers and refugees. They've made recommendations for change, but over 2 years, it seems to have got harder. This is not just an issue in MK, but many other Healthwatch have raised this. So how can the panel suggest national organisations work with Healthwatch to reduce this inequality in access? And can EHRC look at this issue nationally?
So I'm going to let Joan come in first, actually.
Yeah.
Welcome to Jenny. We will give you a chance to settle in and we will come to you after that. Joan.
Just on, I think this is a really great question, because the variability in terms of who gets what, an organisation saying we deliver is huge. There's huge variability. We have a primary care network at the NHS Confederation, as well as a clinical commissioners network, and it's something I suggest we work together with them on. There are those organisations in primary care who just do really, really well, but we get these blanket statements again. So let's try and drill down to what's actually happened. Let's bust, frankly, some of the myths, and let's really go to town on some of the stuff that we just know is happening. And you've got the data, is what you're saying. So that'd be great. That's a suggestion for me.
Thank you. Thank you very much for that. So we were talking, Jenny, about the fact that Healthwatch for many years have reported certain GP practices or lack of access to primary care for disadvantaged groups, including refugees, people who are homeless, etc. So that's where we were coming from. It'd be great to have your views on that specific question, but then also to give you a chance to give your input on health inequalities in particular with relation to COVID-19.
Thank you very much. And I mean, first of all, my sincere apologies for not being able to join you on time. I think when I said yes, and even at the weekend when I said yes, I thought it was all clear. But it changes quite quickly in the current climate, and obviously there's a lot of work ongoing on COVID. I think perhaps if I just answer that very generally, so I know, for example, I've personally have oversight of much of the guidance that comes through, where we particularly try and ensure that groups which are hard to reach, have particular issues in relation to inequalities, are well catered for. So that works both in terms of the developing evidence that we have, so around, for example, minority ethnic groups or people with underlying health conditions, often combinations of that, but again pointing to homeless individuals, for example, and the particular risk there. And undoubtedly, COVID is a disease which is not at all helpful. It will be picking out those who are most socioeconomically deprived, and particularly, for example, in relation to homelessness, one of the problems is, particularly as we're coming into winter now, we're seeing that second phase. People naturally need to come together if you're coming into impromptu sorts of housing and homing arrangements. Those particular environments are very unhelpful and quite dangerous. And we know, for example, for many of the homeless people, that their life expectancy anyway, and the conditions and risks which they carry on a normal day-to-day basis, will exacerbate their risks coming through COVID. So, I mean, on the one hand, that's a very sad picture. I think on the positive side, it's important for colleagues to be aware how much thought and emphasis goes into that in terms of planning. And for me, actually, that guidance and consideration is all considered with Public Health England colleagues and comes through CMO's office. So I think, you know, a bad picture in one way, but positive in the sense that these are well recognised, and where possible, we're trying to tackle them.
Thank you, Jenny. And I wonder if you would like to take the opportunity to give your view on the biggest challenges around health inequalities in COVID-19 and the role of Healthwatch to support that.
Thanks. So sorry, I'm just tackling something on my screen there. Sorry, Danielle, could you just repeat the question?
So all of the other panelists have had the opportunity to give their view on the biggest challenges around health inequalities within the pandemic, and also the role that Healthwatch can play in supporting the tackling of those.
Right. So I think, just going back to those early comments, that one of the main problems is with any infectious disease, and COVID is an example which has suddenly come upon us, is that inequalities actually, as I've said, it's almost seeking out that inequality. So people will be multiply hampered by the virus. So potentially more more frequent exposures, or multi-generational housing, less space around, less opportunity to be outside. I mean, that was very clear, I think, a very prime concern for me as a public health clinician during lockdown, and you'll see that the guidance this time round absolutely recognises the importance of people being able to get out of the home, but in a safe way. So I think it's a whole combination. It isn't one element of inequalities, it's the entirety, but I think it gives us opportunities as well. So if we just take something like underlying health conditions, if we think about obesity, and this, I don't mean that in a stigmatized way at all. Actually, there's a whole construct behind that about access and knowledge and awareness of good diet, the ability to have time and freedom and flexibility to exercise. And I think one of the positive things that may come out from COVID is the realization that these all link together. And it's the whole mixture of our social life and our work life and our opportunities and our education, which combine for us all to be more resilient and for us to be able to tackle diseases. And COVID will not be the last one. New diseases are coming forward on a fairly regular basis. And it's quite possible we could see something, you know, son of COVID in a few years' time, hopefully not to the same extent. So I think on the one hand, it affects all of us. It affects those who are most socioeconomically deprived most of all. Really importantly, it affects life chances. So the focus that you will see currently on keeping schools and education facilities open, we know that if children are taken out of school for any length of time, it's those who are in the highest group of inequalities who will suffer the most, and that then sets life chances for the future, what their education will be, whether they will get a good job in the future, and therefore what their long-term health will be, not just short-term. So all of those are absolutely critical. The role I think which Healthwatch can play is to, it's a sustainable group, it should be a challenging group, and to keep a focus on these points and not let organisations and systems forget that, and to keep pushing through on some of these very basic ones. So basic good health, let's not forget health promotion, physical activity, good nutrition. When COVID, it won't be over, but when we've got it under a degree of control, that's probably going to be sort of next spring on. So keep an eye on this, but really keep promoting general resilience and the wider issues of public health like education.
Thank you. That's very helpful, Jenny. And I'm going to take one last question for all of the panel members to ask, and I think this time it's going to be Brian. I always get it wrong.
This one's from Herefordshire. So during COVID, in a very rural county like Herefordshire, a new disadvantaged group has arisen. Those often elderly who have little or no access to internet-based services. Many newly designed services, such as remote GP appointments, assume that all can access them. What can be done to overcome this?
Thanks. Shall I go for that one?
Yes, you go first.
Yeah, thanks. Yes, really, I know Herefordshire well. I live next door in Monmouthshire, actually, so that's very close to home to me. Absolutely understand the rurality, and you definitely do get rural inequalities in health and in health access. Of course, there are benefits as well, so lots of green space around is also quite positive. I think the digital divide is a really important one as we go forward. Clearly, as younger children come on board, I mean, I'm still of the group which, although I hesitate to highlight my age, that didn't have computers when we started off, and have had to learn, unfortunately, have been in that learning experience. But for older generations, as you say, these are not as accessible. There is a strong push within the NHS and within Department of Health policy to try and ensure that where possible that is remembered. I think inevitably, because it's possible to reach large numbers of people very quickly, and for something like COVID, for example, that's a very positive thing. We don't want to stop doing that, because that's positive for most people. But equally, I do quite a lot of work on the clinically extremely vulnerable group, and we're really mindful of this. So you will see that the hard copy paper letter will still go out, even though the background letter will be sitting on the web. So I think assurance on the one hand that is considered. In terms of actual access to GPs, I think it comes down much more to having GPs who are very familiar with their communities and with their patients, and being able to recognise when different people need, differentiated service provision.
Thank you, and it's really good to hear that is being considered. Anna, and then Jag.
I think as a patient, it's just services need to remember that when they bring these things in, different people will have different needs. So like my GPs have brought in this digital thing, you have to go through this questionnaire, and actually I can't complete that questionnaire because it always says I have to go to A&E because of my long-term conditions, but I don't need to, and it's those sort of things that if we designed them with patients in the first place, and we practiced with some people, and we brought them in a thoughtful way, and then we were able to be flexible. So when I then ring the reception, they say, no, you have to complete the form, and it's like, but you go around in the cycle, and it's how we as a I think they're great for most people, but it's how we capture those experiences and how we then use those to actually improve things as we go along. And we're doing a continuous improving and listening to people's experiencing and remembering that, and allowing the system and the people that work in it to be flexible when it doesn't work for someone, because it's one size does not fit all. People are different. Thank you.
Thank you very much. Now, Caroline, I've noticed in the chat, one of the comments is that this is where equality impact assessments come in, if they're undertaken appropriately when the changes are being made. So over to you for comment, Caroline.
Yeah, that was exactly the point I was going to make, actually, that we've got tools to help us get these things right. Now, I do understand that there are, sometimes we just have to act with speed, but that doesn't mean that we can't use things like the public sector equality duty to make sure that at the concept stage we've got these things right, and then use the equality impact assessment to really confirm what we need to do. The other thing is that it is right that we react quickly to reach the most in these kind of urgent situations. But we then need to very quickly after that make sure that the minority that are not getting access don't get forgotten and left behind. And so I would really like to see Healthwatch really holding to account people, asking those questions about, well, look, where is the evidence that this reaches everybody? And I'll give you an example of the work that we've done at the Equalities and Rights Commission in working with the Ministry of Justice, looking at how the introduction of technology, trial by technology and everything else has worked. And it hasn't for people with disabilities, particularly people with learning disabilities, people who are, dispossessed out there on the streets and everything else. It just doesn't work. It's not okay for that not to work. So we have to come back to, what do we do at the point of introduction? It can't always be an afterthought. And I would like to see a kind of constant mantra of diversity built in. Because, I am so sick of hearing that we have hard to reach people. We don't have hard to reach people. We have hard to reach services.
Very, very powerful point, Caroline. Joan, you've got your hand up.
Yeah, hard to reach services, which we all pay for, by the way. So I wonder, so I don't have anything more to say on the digital point. Agree absolutely, particularly the last point. I just wanted to raise that this mirrors the point we talked about with people not getting access to care homes a bit, this blanket kind of policy, everybody will do it. And one of the things we said was, why can't we take concerted action? And I wonder if Dr. Harries had any information on what we might do, because it's so important. We all want to do the right thing. How can we all act together with Healthwatch was the question that came up before you came, Dr. Harries, but it's great to see your approach on these things. Is there anything you could do for us? I'm taking that opportunity because a Healthwatch person asked it, Danielle, so I'm speaking.
That's absolutely fine. I'll just flesh out the question for you, Jenny. So the question was really on the basis of the fact that people in care homes, that there was a blanket, over 75s are vulnerable, and that meant that a lot of people in care homes didn't get services, that there was a widespread use of DNA, etc., without proper consultation. So it was really about how can we work together to have a more tailored approach.
So there are a whole host of questions within that one question, and I can see one up on the list about visiting, for example, as well. So I, as a public health doctor, I see this from different perspectives, and I actually chair the SAGE subgroup on care and care homes, and that was actually set up to get a handle really on the evidence when we were seeing large numbers of vulnerable people sadly dying in the first wave of the epidemic, to see were there things, was there evidence there that we could implement to make sure these environments were as safe as possible. Unfortunately, age is the most dominant risk factor for COVID-19. But it's not the only one, and it certainly doesn't mean that people shouldn't be able to choose, if you like, what is important to them. The difficulty with the care home environment is that an individual's choice actually affects other people's risk, and so this is a really, really complex topic. So if, for example, I'm a visitor and I go to the care home, the person I'm visiting might say, and I might add, I lost my father just before the COVID, but very familiar with how this feels. You know, I may have been visiting my father. My father, I know, would have said, I don't care about COVID, actually, I want to see you, and I'm happy to swap some days of life expectancy for that. However, the problem is that my visit also provides a risk to many other people as well. And this is where it gets really difficult. But I think also it's absolutely recognised that for many people, whether it be elderly, whether they have particular conditions, so for example, people with dementia are often very dependent on recognising a particular person, say from their family or their partner, and the isolation from that individual can cause quite severe, not just mental anxiety, but physical deterioration as well. So the reason I say all of that is because I think sometimes the way it's somehow become pitched as a, they won't let us, or they, you know, why can't we? Actually, all of these things are really under detailed consideration. And in the SAGE subgroup, we've been trying to work out some sort of way of getting a balance point on that is acceptable all the way around. And I think it's almost impossible to quantify, but people want to protect. What we saw the first time round was a lot of people succumbing to COVID, and clearly there is a responsibility to protect individuals as well. So when that comes back to, you know, how do we, I'd hesitate to say treat people, because it's not a treatment option and it's not what we do to people, it's how people live their lives successfully with support. And trying to get all those balance points right is difficult, particularly in the current climate where obviously we've got rising rates again. But I think I'm just, in fact, one of the reasons I was late to the meeting was on this very topic, so I can't give you the detail, but I think be reassured that that understanding is absolutely there. It's the solutions that are more difficult. So I think what we will see going forward are options edging towards safer approaches to visiting, to try and open it up more, but equally to do that in as safer way as possible. So if we have new sorts of testing for available, that also becomes another tool to allow visiting, but to make sure it is as safe as possible. And I recognise, I mean, the DNA statement, I think is misperceived. I would just say, often what I think is happening is very good clinical decisions are made around treatments, and sometimes that is misunderstood or misinterpreted. So I have seen no evidence at all in clinical care or anything that I've been involved with of any condition issues to do with blanket statements. But I think sometimes, often what we need is really good explanation of how people are being supported, what clinical care is appropriate and why, and making sure that that is understood not just by the individual, but by the family and by the carers as well. And just on a final point, actually then, just for absolute clarity, visiting has been allowed. I realise we're now going into an even heightened period, so, but visiting has been allowed, and I think care homes are concerned and anxious about that additional risk to others in their care. They are there to care for people. So it's really difficult for everybody, the individuals themselves, their relatives who miss them, but the care providers in the care home and the policy makers. So I think we're all trying to do the same thing.
Thank you very much, Jenny. So sorry I won't be able to come back to you, Jag, actually, because we are out of time, and I don't want to start losing panel members because I think people have got other meetings to go to. So it has been a fantastic conversation. I'm really appreciative of the contributions of all of the panel members, and also for the questions coming in from the Healthwatch audience. Now, clearly, we are going to be continuing to focus on health equity throughout this Healthwatch conference week. It will be informing how we prioritise our work. We've had some great ideas and suggestions that have come from this discussion today. With lockdown coming back into force, we will be reviewing our resources at Healthwatch England about how we can better support your staff and volunteer wellbeing, because obviously we want to really make sure that we help you get through this second lockdown. However, if there are any resources or guidance that you need and you would like us to prioritise here at Healthwatch England, please can you contact us either in one of the sessions or on the Workplace COVID-19 group. So it's just now to say thank you and look forward to seeing you at other sessions, and thanks to the panellists. Thank you very much.